we're going to talk about effective E&M documentation, or essentially how can you apply these complicated rules that we discussed in the previous presentation. Undercoding for medical services is a major problem. An audit of 351 family practice notes showed that 33% were undercoded by a basic audit. However, if you just considered the medical decision-making component of the bill, 50% of the visits were undercoded, and it approximates what could have been coded if the history and exam sections were documented at the level that would support what was discussed in medical decision-making. And if you just looked at the number of presenting problems, 80% of the visits were undercoded if they could be supported by a properly documented history, exam, and medical decision-making. This is a huge issue. If you look at a hospital admission, undercoding by just one level can reduce the Medicare allowable charge by 26 to 33%. If you undercode by 2 levels, it reduces the Medicare allowable charge by half. Particularly in this era of change in the healthcare delivery system and the shifting focus to not only quantity-based services but quality-based services, this is very important. This triple challenge of cost, quality, and value is dramatically impacted by your ability to effectively document and bill for healthcare services. We're going to talk about a patient case. This is an inpatient follow-up visit of somebody who came in with chest pain. You've probably seen notes like this. So subjective, the patient had stent placed last night, doing fine, no complaints. Objectives, you have vital signs, cardiovascular exam, lung exam, abdomen exam, and a discussion of the laboratory studies. Assessment and plan, ST elevation myocardial infarction. He's had a stent placed. He's on dual antiplatelet therapy, a statin and a beta blocker. He's a smoker. We encouraged him to quit, and we plan to send him home tomorrow. Unfortunately, this documentation is not compliant with the 1997 E&M guidelines, and it's not a billable encounter note. So if you look at the inpatient follow-up encounter documentation requirements, for a level 3 visit, you need to have a detailed history, a detailed exam, and high medical decision making. Again, it's one of those, since it's a follow-up, it's 2 of the 3 components of history, exam, and medical decision making should be at that level. And as previously, I strongly suggest that you set your medical decision making at the level required for that service. So our E&M encounter needs a detailed history, a detailed exam, and high medical decision making. So we're going to talk about the history first. We need a chief complaint, a history of present illness, a review of systems, and a past family and social history. So the HPI needs 4 elements for the status of 4 chronic conditions. The review of systems needs 2 or more organ systems, and a past family and social history is reviewed and updated as necessary. This is called an interval history, and this can be seen in detail in the 1997 E&M guidelines. So for our patient, we could say chief complaint, ST elevation myocardial infarction, history of present illness, a 55-year-old admitted with exertional chest pain of 4 hours duration due to ST elevation MI. He underwent placement of drug-eluting stent last night and is now chest pain-free. He has no dyspnea or other symptoms. Review of systems, cardiovascular, no chest pain or palpitations, respiratory, no cough, wheeze, or dyspnea. Past family and social history reviewed with no updates. That's pretty straightforward, isn't it? So we've met our history requirements. We're going to talk about examination. We need to document 12 bulleted items from the 1997 E&M guidelines. So for this patient, we can document the vital signs. We could do general, no distress, he's conversant, neck, full range of motion and supple, lungs clear, cardiovascular, regular rate and rhythm, no murmurs, normal carotid upstroke with an amplitude without bruits, abdomen soft, non-tender, no masses or hepatosplenomegaly, extremities, no edema or cyanosis, skin, no rash, lesions, or ulcers, psychiatric, alert and oriented to person, place, and time. And that would really meet all of your requirements for a detailed physical examination. Medical decision making as defined by the 1997 E&M guidelines. You look at problems and treatment options, data reviewed, and risk. So data reviewed, EKG shows a normal sinus rhythm, meaning that you reviewed that. Laboratory studies, including an LDL of 120 and a creatinine of 1, and you discuss the patient with the cardiology attending. Assessment and plan, ST elevation MI. He has received a drug-eluting stent and is on dual antiplatelet therapy. He has on a beta blocker and a statin. His left ventricular ejection fraction is not reduced. Coronary artery disease. He's had a myocardial infarction. He's on a beta blocker and a statin. Hypertension. He's on a beta blocker. Hyperlipidemia. He's taking a statin. Tobacco abuse. You've counseled him to stop smoking and disposition, likely home tomorrow. So that meets the necessary items to qualify for high levels of medical decision making. Remember, you need to document only 2 of the 3 of these components at this level or higher. So we'll go through our example in its entirety. We have a patient with chest pain, chief complaint ST elevation MI, history of present illness, a 55-year-old admitted with exertional chest pain of 4 hours duration due to ST elevation MI. He underwent placement of drug-eluting stent last night and is now chest pain free. He has no dyspnea or other symptoms. Review of systems, cardiovascular and respiratory are discussed. Past family and social history are reviewed and no update. Physical exam, you document the vital signs. A general exam, neck, lungs, cardiovascular, abdomen, extremities, skin, and psychiatric. Medical decision making, you discuss the data that you reviewed, the EKG, which you reviewed the tracing, laboratory tests, and discussing the patient with another physician. So your assessment and plan, ST elevation MI, coronary artery disease with history of MI, hypertension, hyperlipidemia, tobacco abuse, and plan for disposition. Remember, you only need to document 2 out of the 3 areas at this level or higher. I strongly urge you to consider documenting history and medical decision making at the level required for the service you're billing or higher. This really clearly documents the quantity of medical services that you're providing and the quality of the medical services you're providing, and addresses the issues of cost, quality, and value in the context of this particular patient encounter.